Welcome back to our next session for day 2 of the 2022 Cancer Research Institute Virtual Immunotherapy Patient Summit. It's time to talk about breast cancer, the leading cancer in women after lung cancer. Joining us to talk about advances in immunotherapy for breast cancer is Dr. Elizabeth Ann Mittendorf, who is the Director of Surgical Research, Director of the Breast Immuno-Oncology Program, Co-Director of the Breast Cancer Clinical Research Program, and a physician and professor of surgery at Harvard Medical School and Brigham and Women's Hospital in Boston. Be sure to share your questions for Dr. Mittendorf by typing in the Q&A box. Brian Brewer from the Cancer Research Institute will pass those along during the session. Thank you, Dr. Mittendorf, for sharing your expertise with us today. Let's learn about breast cancer immunotherapy.
Thanks, Tamron. And I wanted to thank the Cancer Research Institute for inviting me to be with you all today to discuss immunotherapy and breast cancer. This is a really critical summit for patients and caregivers, and I'm glad we're all able to be here together. I was thinking about it when we first discussed including breast cancer in this summit, and I was thinking to myself, my goodness, if we had been doing this 5 years ago, I would probably need less than 5 minutes. Our initial efforts to use immunotherapy in breast cancer were largely unsuccessful. But in the last several years, we've had a number of what we call positive trials, meaning clinical trials that enrolled patients and showed benefit to giving them immunotherapy in addition to chemotherapy in both metastatic and early stage breast cancer. And so now I think we'll be able to take the full 30 minutes that were allotted to go through a few slides here and then open it up for hopefully a very nice discussion. The slide that I'm showing here, you can see are the breast cancer subtypes. So the point of the slide is that breast cancer is not breast cancer is not breast cancer. There's a number of varieties of breast cancer. So when I'm talking to one of my patients, I'll let them know that once the pathologist tells me that the diagnosis is breast cancer, there's additional information I ask of them, which is critical in helping us determine the subtype of breast cancer, which is really important because it helps to determine what's the appropriate therapy for that breast cancer. And so what I ask them is, do these tumor cells express the estrogen receptor and the progesterone receptor, which together are the hormone receptors, HR on this slide? And does it express the HER2 receptor? And this is really important because, as I alluded to, it tells me and my medical oncology colleagues how best to treat a patient. So, as an example, a patient who has a hormone receptor positive breast cancer is going to benefit from endocrine therapy. So, you may have heard of drugs called tamoxifen or aromatase inhibitors. These target that estrogen receptor. And for patients who are HER2 positive, there are a number of drugs now that target the HER2 receptor. You may have heard of a drug called trastuzumab or Herceptin. That was really the first HER2 targeted therapy, and in my opinion, was really a game changer. I remember the meeting where the trial data was presented, standing ovation, as it was shown that giving trastuzumab to HER2 positive breast cancer patients in the adjuvant or after surgery setting decrease the risk of recurrence by about 50%. And I actually like to suggest that trastuzumab or Herceptin may actually have been an initial immunotherapy success story in breast cancer because trastuzumab is what we call a monoclonal antibody. And we've subsequently learned that there are a number of mechanisms of action of trastuzumab that rely on stimulating the immune response. And so if you look at this slide, you can see that the majority, about 70% or so of breast cancers are hormone receptor positive, HER2 negative. About 15% of cancers are HER2 positive. So those patients get that drug trastuzumab and perhaps pertuzumab and other HER2 targeted agents. And then in the red, you see that about 13% of breast cancers, in fact, don't express either the hormone receptors or HER2, and we call that triple negative. And if you were to do a Google search for triple negative, I think you would probably find some sites that would suggest that it's the bad breast cancer. And this is largely because we haven't had therapies that are specific for triple negative breast cancer. There was no target. So, no targeted therapy. All patients got chemotherapy. But in fact, in the last several years, there have been a number of trials that have shown success in using some novel agents. And the one that I think was the biggest blockbuster was the trial that showed the benefit of immunotherapy in triple negative breast cancer. And so on this slide on the far left, what you see are some of the treatment modalities that most breast cancer patients are offered: chemotherapy, radiation, targeted therapy. That's the trastuzumab or Herceptin for the HER2 positive, or the endocrine therapy for the HR positive. Not shown here is surgery, which is also a pillar of cancer care. But the reason that the chemotherapy, radiation, and targeted therapy are shown is because one of the things that those agents do when they affect a tumor, basically causing the tumor cell to die, what it causes is release of antigens from that tumor. And you can think of antigens as tags from the tumor that kind of identify it as such, or identify it as foreign, to potentially be recognized by the immune system. And how does the immune system recognize it? Well, the way it works is these antigens, which are the little red triangles shown here, are taken up by dendritic cells. Now, dendritic cells are your immune system's most effective antigen presenting cells. So the dendritic cells can put those antigens, those red triangles, up on the cell surface complexed with what we call HLA molecules. You can think of those as small easels that put those antigens up on the cell surface so that immune cells, like T cells shown in green here, can recognize them and be educated that, hey, this is foreign. When you see this antigen, when you see the red triangles, go after it, attack, and destroy. The T cell shown here is a killer T cell. It's a CD8 positive T cell. And these are the ones that are able to do what I just suggested: recognize something as foreign, attack, and destroy. And so this is really important when you have an immune response against the common cold, against a scratch or a wound, but also an immune response against cancer. Now, one of the things that happens when a T cell gets activated, it gets a bunch of go signals. This is foreign, go after it. But you don't want your immune response to go seemingly out of control, particularly if the immune response is against the cold or a cut or something like that. But in fact, if your immune response is against your cancer, you kind of do want it to keep going. You don't want the brakes to be put on. You want it to just go, go, go. And so when the T cell puts up the stop sign, one of the things that we've learned is that there are drugs, immunotherapeutic drugs called checkpoint blockade drugs, that you can administer to patients that will effectively take the brakes off. So it'll allow that immune response to keep going, which, again, if your immune response is against your cancer, that's exactly what you want to have happen. You want that immune response to keep going. And so it turns out that the one of the most common pathways that causes these breaks on the T cells is the PD-1 PD-L1 pathway. So PD-1 is the receptor that the T cell puts up to say, "Whoa, let's slow this down." And PD-L1 is its ligand on the cancer cell. And when that connection is made, it does just that. It causes the T cell to kind of turn off. And so what you want, of course, is to prevent that from happening. So, again, back to our drug, the checkpoint blockade, it basically sits in between the PD-1 and its ligand PD-L1, blocking that pathway so the T cell doesn't get turned off and it keeps going. So it continues to recognize the cancer cells, continues to attack and destroy. So, one of the interesting things, at least that I've always thought about immunotherapy, is you could argue we're not treating the tumor per se, but we're treating the immune system. We're making the immune response more robust by taking off those brakes. And so this is a cartoon that I kind of like because it shows that when you take those brakes off, when you inhibit the PD-1, PD-L1 interaction by giving checkpoint blockade, then the killer T cells, they keep going, they continue to attack and destroy the tumor cells, and then the cancer is eliminated. And so, as I alluded to, some of our initial efforts using immunotherapy in breast cancer were arguably just disappointing. And what we learned was that you probably can't give immunotherapy alone. In fact, in breast cancer, the successful trials have shown that immunotherapy should be combined with chemotherapy. And one of the first studies that showed that enrolled patients with triple negative breast cancer that was metastatic and positive for PD-L1, meaning the cancer cells expressed PD-L1. And so in this trial, it was called the Keynote 355. Patients with metastatic triple negative breast cancer that express PD-L1 who were given the immunotherapy in addition to chemotherapy were compared to patients that got chemotherapy alone. And the addition of that immunotherapeutic agent, the pembrolizumab, resulted in longer survival. And so, based on that, we routinely now test patients with triple negative breast cancer that's metastatic to see if their tumor cells express PD-L1. And if so, they would get pembrolizumab in addition to chemotherapy as a standard regimen. Now, having shown the benefit of immunotherapy in patients with advanced or metastatic breast cancer, the next logical question was, might it benefit patients earlier in their stage of disease? And so we conducted a number of trials, including the Keynote 522 study that enrolled patients with triple negative breast cancer that was stage 2 or 3. So not metastatic yet, so curable. And what this study did was to give patients either chemotherapy plus placebo or chemotherapy plus the pembrolizumab. And what the study showed was that for those patients who received pembrolizumab, it was more likely that they were going to experience a pathologic complete response. Meaning, if we gave the treatment in the neoadjuvant setting, which means before surgery, when I, as a breast surgeon, performed an operation and the pathologist looked at that specimen under the microscope, there was increased likelihood that there would be no tumor cells left. Now, also quite important is that whether a patient experienced a PCR or not, just by getting the immunotherapy, they had improvements in what we call event-free survival, meaning it was less likely that the cancer is going to come back. And I think this is a really important feature of immunotherapy, which stimulates, again, a T cell response, which in immunology language means it's an adaptive immune response, which means that it is potentially lifelong. On the third bullet point here, you see a note about a drug called olaparib. That's a drug that's in a class that we call PARP inhibitors. And these drugs have now been demonstrated to be beneficial both in the metastatic setting as well as the early disease setting for patients who have breast cancer that's due to a BRCA mutation. So, mutations, those are alterations or abnormalities in your genes that you picked up from mom or dad. They account for about 5% of breast cancers. And we know that patients that have a BRCA mutation benefit from these drugs called PARP inhibitors, such as olaparib. And I think one of the really interesting questions is what about for our patients who have BRCA mutated metastatic triple negative breast cancer, and they may benefit from a PARP inhibitor, they may benefit from immunotherapy? What's the order in which we should give these agents? And then I would be remiss if I didn't highlight the final point on this slide that says clinical trial enrollment remains a priority to further understand benefit of checkpoint inhibition in breast cancer. We would never have learned that triple negative breast cancer, whether they have metastatic disease or early stage disease, benefit from immunotherapy if patients had not generously enrolled in these clinical trials that demonstrated the benefit of adding immunotherapy to chemotherapy. And there's a lot more to do. We need to figure out who benefits, who gets toxicity. We need to determine how long a course of immunotherapy patients should get. We need to make immunotherapy work in our patients with subtypes of breast cancer other than triple negative, so those with HER2 positive breast cancer and hormone receptor positive breast cancer. And we're only going to be able to do that through the conduct of very thoughtful clinical trials. And so, with that, I think I will stop because I want to make certain that we leave plenty of time for questions and discussion. And I'd again like to thank the Cancer Research Institute for inviting me to participate in this immunotherapy summit with all of you. Thanks so much.
Thank you so much, Dr. Mittendorf, for that presentation on breast cancer immunotherapy. It sounds like there's been a lot of progress in just the recent past, which is wonderful to hear. I too remember those early days when breast cancer, which is the leading type of cancer diagnosed in women after lung cancer, or leading cause of death after lung cancer, there just wasn't anything much to report. So wonderful to see the progress. So thank you for sharing that with us. I'd also like to thank Dana-Farber Cancer Institute for being one of our institutional partners this year with our virtual immunotherapy patient summit. All right. So those of you watching have an opportunity to ask Dr. Mittendorf questions by typing in the Q&A box. Some of you submitted questions at the time of registration, and so we'll get to those right now. Dr. Mittendorf, what makes breast cancer harder to treat than other types of cancers I've heard can be treated with immunotherapy and don't require combinations?
That's an important question. And I think that we can actually look at the types of breast cancer where it works to help get that answer. And so, as I alluded to, it seems to be more effective in triple negative breast cancer than hormone receptor positive breast cancer. If you look at breast tumors under the microscope with a pathologist, you'll see that the triple negative tumors are more likely to have lymphocytes or T cells, more likely to have these immune cells infiltrating into them. Hormone receptor positive breast tumors really have a lack of those T cells. And so I've said somewhat, maybe a little bit tongue in cheek in the past, that if immunotherapy is taking the brakes off of T cells, of course it's not going to work in a tumor type that doesn't have a lot of T cells. But I think that's a little too simplistic. Your question, though, it actually makes me think too of the initial tumor types where immunotherapy did work, and that was melanoma and lung cancer. And we know that melanoma and lung cancer are due to carcinogens, so UV exposure and tobacco, respectively. And it's thought that those carcinogens result in a lot of mutations. And those mutations end up being those flags, those antigens that I referred to earlier, that basically identify a tumor as being something that's foreign that the immune system should attack and destroy. So I think in breast cancer, if we're going to continue to progress, we're going to need to figure out how best to make the tumors visible to the immune system, more like lung cancer or melanoma may be.
Is there any exciting work ongoing there in that area, or are there clinical trials where doctors are attempting to do just that in breast cancer patients?
There's absolutely a lot of work going on in this area. In fact, our group at Dana-Farber is doing some work, particularly in hormone receptor positive breast cancer, to figure out why, in fact, there's not much of what we call an endogenous immune response. So why, when the pathologist looks under the microscope, does it not have many lymphocytes? And what we're finding is that there's defects in that antigen presentation machinery. And so if that's the case, you could envision in a subsequent clinical trial evaluating an agent that may in fact enhance antigen presentation, so you get more of an endogenous response, bring in T cells, then bring in checkpoint blockade. So you bring in the T cells and then you take the brakes off. So there is a lot of interest in this. I would just emphasize that I think we have to be really thoughtful and do good work in the laboratory using specimens from our patients to learn more about the immune microenvironment so that we can in fact be thoughtful in the conduct of trials.
Here's a question just about the treatment experience. Many people are familiar with how they receive chemotherapy or what radiation treatment looks like, but not many people understand what immunotherapy might look like when you're actually receiving it. What is that like? What that experience for a patient?
So that's a good point. If you're having surgery or receiving radiation, you clearly know that you're in the operating room or getting radiated. Chemotherapy, the same thing. You're in the infusion center and you're getting the infusion into your veins. And actually, that's how immunotherapy is given as well. It's given intravenously. One thing that I'd like to highlight with the question that was asked was that, in fact, immunotherapy has different toxicities, meaning different side effect profiles than chemotherapy. So even though they're both administered through the veins, they might be very different with respect to side effects. As an example, chemotherapy might cause someone to have abdominal discomfort that we might just say, okay, take Imodium with the diarrhea, it's going to resolve. But if you have those same symptoms with immunotherapy, it might be something completely different. It could be colitis. So doctors talk about itises, meaning inflammation. So you can have an itis just about anywhere. And if you have an itis while you're on immunotherapy, it may be due to the immunotherapy because those T cells are revved up and they're not just affecting the tumor. And so even though immunotherapy is administered through the veins like chemotherapy, I think we have to be really cautious in how we educate our patients to make certain they know the potential side effects that should prompt a phone call to the office for further evaluation.
Very, very good advice. There's another question. If it's about the duration of treatment, how long someone might be expected to receive immunotherapy? Does it last forever, or do you get to have that moment where you ring the bell and you're done with your treatment?
So that's an interesting question just based on what immunotherapy is. It's stimulating an immune response. And if you stimulate an adaptive immune response, in theory, it could be lifelong. Having said that, for patients who receive, let's say, earlier stage, so stage 2 or 3 triple negative breast cancer, the standard now is to give immunotherapy before surgery. And the clinical trial that showed that benefit actually continued that immunotherapy for a total duration of 1 year. So the immunotherapy was continued after the surgery as well. Now, one very interesting question is if you get that immunotherapy with your chemotherapy before surgery, and at the time of your operation, there's no cancer left, do you need that additional immunotherapy on the back end? And in fact, there's going to be a very important clinical trial run through what we call the NCTN, the National Cancer Trials Network, that's going to ask that exact question. So if patients experience a pathologic complete response, can we stop the immunotherapy? That's the early disease setting. The later stage disease setting is a little bit more difficult. We generally tend to treat patients until they either progress or they develop toxicities. And so that's going to be managed individually with the patient and their provider.
Speaking of toxicities, of course, lots of questions about side effects and how they're managed. But this one is an interesting question. If I'm receiving immunotherapy for breast cancer and have a bad reaction from side effects, can I stop it temporarily and go back on, or is that it for me for immunotherapy?
The questions or the answer is it depends. And so, as I alluded to in responding to one of the earlier questions, there are a number of different toxicities. So, we talked about the itises. You can get thyroid hypothyroidism, hyperthyroidism. You can have colitis. You can get hypophysitis. You can get a pulmonary toxicity. And it kind of depends on the degree of the toxicity. Your provider may stop the immunotherapy, and then when the toxicity resolves, restart it. They may stop it and have to give you steroids to kind of reverse the immune effects and then consider restarting it. It really depends on the individual patient, the toxicity they experience, and the extent or degree of that toxicity. And so this is something that breast medical oncologists over the past couple of years, once we've gotten approvals for these agents, we've actually learned quite a bit from our colleagues in melanoma and lung cancer on how best to manage these toxicities. But it really just kind of depends.
Here's another question. Breast cancer runs in my family. I've had a double mastectomy as a preventive measure. Should I now consider immunotherapy also?
So the answer is no. There's probably a lot more information that I would need to really answer the question thoughtfully. So the suggestion was that breast cancers in the family, there was a mutation, and the bilateral mastectomy was done prophylactically, in which case you did the surgery in the hopes that you would never have a breast cancer diagnosis. If the surgery was done in the context of a mutation and you had a cancer and the double mastectomy was the surgical part of your treatment, then hopefully you've continued your care as advised by your physician. Let's hope we don't have a situation where in the future you develop symptoms somewhere else, bone pain, abdominal pain, cough, headache, in which case your doctor would want to do an evaluation and make sure cancer hasn't returned. If there's something on imaging that would suggest it has, then a biopsy would be performed, the receptors would be determined, And if it was triple negative, they would look for PD-L1 expression. But let's hope that doesn't happen. But there's no indication for routinely giving immunotherapy to a mutation carrier.
Thank you for answering that. And just to reiterate, you make a great point that everyone's treatment plan is different. Everyone's cancer journey is different, and anyone asking these questions should consult with their healthcare team and take this back with the point of this being to arm you with information and questions that you can take back to your healthcare team to make the decision that's best for you or for a loved one. All right. Just wanted to say that. All right, here's an interesting question. It's about the future in a way. I'm thinking about breast cancer treatment 10 years from now. Will surgeries like lumpectomy and mastectomies and treatments like chemotherapy be a thing of the past?
I don't think so. And one thing that I think I would point out is that the very first slide I showed, about 72% of breast cancers are hormone receptor positive, HER2 negative. I actually think the way we're moving as we learn more about hormone receptor positive breast cancer and the use of things such as genomic assays to learn further about the genetics of the tumor, we're going to actually find that there's a group of women who all they'll need is surgery. So perhaps all you're going to need is me to take you to the operating room and spend 30 minutes together to do a lumpectomy, and then you'll be done with surgery. You may not need radiation, and then the medical oncologist would give endocrine therapy. I think the question about where are we going is not necessarily to omit any treatment or get rid of a treatment, but use what we've learned about these effective modalities, surgery, radiation, chemotherapy, targeted therapy, immunotherapy, to really personalize and right size each patient's treatment for their individual tumor and diagnosis. So I don't think they'll be a thing of the past. I think they will be refined for the individual patients.
Hmm. We talked about checkpoint blockade therapy largely in the context, but there are other types of immunotherapies. There are vaccines, oncolytic viruses, CAR T-cell therapy, which is another type of immunotherapy. Any advances in those areas for breast cancer that patients should be aware of or ask their doctors about?
I appreciate the question, particularly about vaccines, because that's where I initially started my work in immunotherapy. We had identified an antigen derived from the HER2 protein that elicited an immune response. And so our group had done a number of clinical trials, including a phase 3 study, which for the audience, phase 1 shows something safe, phase 2 shows that it's not only safe, but it may be effective. And then phase 3 is a much larger study to show that, in fact, yes, it is effective. And what we found, unfortunately, or fortunately, was that giving the vaccine by itself was not beneficial with respect to preventing recurrence. But we learned a lot from that. And I think there is a tremendous amount of interest in vaccines to do what you and I were talking about earlier. Vaccines stimulate an immune response. So maybe we need to be giving a vaccine first to bring in the T cells and then give checkpoint blockade. I think that there are a number of other immune cell types that we are just now beginning to learn a lot more about. Macrophages come to mind that are very abundant in tumors, to include breast cancers, to include hormone receptor positive breast cancers. So maybe in hormone receptor positive breast cancer, we'll need to be going after a different immune cell type. With respect to CAR T cell therapy, as I think probably many know, the successes to date have largely been in what we call liquid tumors. So in blood cancers, not as much success in solid tumors. And I would anticipate that we would need successes in other solid tumors before we would use them in breast cancer. And that's in part because we have so many effective established therapies in breast cancer that CAR T cells would kind of be at the end of the line. And so I think we probably will get there eventually, but a ways to go.
Are there any age considerations when someone that has breast cancer and is considering treatment options? Is immunotherapy for people of a certain age, or is it all dependent on what factors? I
I
guess
think
it's a
it's
question about
dependent.
eligibility.
Yeah. So, well, one thing, of course, we tend not, when we look at our clinical trials, we tend not to enroll patients at extremes of age. But having said that, there's no reason that it wouldn't be considered for an individual patient. And there is some data about giving immunotherapy in elderly patients. One of the things that I like to do in my own practice is treat patients based on their physiologic age, perhaps not their chronologic age. And so we have a conversation, myself with the medical oncologist, about whether or not the patients might be candidates for immunotherapy. But there's no FDA label per se that says you can't use in folks over a certain age or in folks under a certain age.
I'm in New York, well, close to New York City, so had a little bit of a siren there. Um, so we actually are out of time. This has been extremely fascinating, wonderful to, as I said, to see so much progress in breast cancer. Before we go, is there anything you'd like to say to a patient or caregiver who's just received a breast cancer diagnosis? And I liked what you said at the beginning. 5 years ago, this would have been a much shorter presentation. But what words do you have for those going through this journey now for the very first time?
I encourage my patients to be optimistic. And I say that because, as we've kind of been talking about, we have learned so much in the last 10, 20 years where we are really able to tailor treatment to the individual patient and their tumor. So be optimistic, learn all that you can about your tumor and your treatment options, ask questions, and work with your providers, your care team, which should be multidisciplinary: medical oncology, surgical oncology, radiation oncology, supported by pathologists and radiologists and genetic counselors. This is your team, and work with them to come up with the best plan of care for you. And breast cancer outcomes have improved significantly.
Well, that is a word of optimism and encouragement, and hopefully inspiration as well for those watching our audiences. Thank you so much, Dr. Mittendorf, for talking to us about breast cancer immunotherapy and all the exciting progress happening there. Once again, I'd like to thank Dana-Farber Cancer Institute for being a host partner institution for this year's program. And then, of course, all of you watching, if you want to share this information, if you found it valuable, if it inspired you to explore your clinical trial options, don't forget that we do have clinical trial navigators standing by to help you in English or in Spanish find a clinical trial that might be a good match for you. Otherwise, please be sure to take this information. It'll be made available on demand. You can watch it anytime or share it with your friends. And with that, thank you so much again, Dr. Mittendorf, and all of you. Wish you well.